everyone for this personal health SIG workshop. This time we have this in English. We have some guests from other countries today. I will start with some introduction. This personal health SIG is HL7 Finland group that is focusing on the personal health applications and online services for healthcare customers, and we have a small core team with Anna Korpela from Kela, Minna Linsamo, Emilia Varonen from DHL, and Hannu Hyttinen and Mikael Rinnetmäki from Sensotrend, and myself from VTT Technical Research Center of Finland. And of course, we welcome any other active persons to participate this core group in organizing these events. In addition to this kind of workshops, we carry out projects in this field. For example, the continuous activity together with Kela and DHL to define the data model for the national Kanta PHR and other specifications. So especially we are facilitating the participation of companies in this work. And we also have each year targeted projects for certain specific areas in personal health, like secondary use of data this year. The topic of today is reimbursement of digital health. This topic relates to the big question that how we really can improve healthcare and use maximally the digital services. A big challenge is that we have a lot of these kind of services, but they are not really used in the context of the healthcare services. They are used independently by people, and we are lacking mechanisms that would empower both the customers of healthcare and the healthcare professionals to identify which health applications could be useful and which are of sufficient quality and security and could be helpful for the patients. We are also lacking mechanisms that would motivate the use of health applications. Could we actually reimburse part of the cost of the application in the same way as we reimburse medication? We will hear today some different perspectives to this kind of application prescription, from at least from ORCHA, UK, Tim Andrews, Nordic Interoperability Project, Anders Tunold-Hanssen, and for Germany, the DiGA approach will be presented by Mikael Rinnetmäki, because this time we couldn't get anyone from Germany to present this. And what is also true is that the precondition for this kind of application prescription is that we really have standards that define the quality and reliability requirements for these applications. And there is now a new standard in this field, and we have Terhi Holappa from Lapland University of Applied Sciences to open what kind of standard this is. Still, another big challenge has been information flow between the customers and healthcare services. The legislation there is a legislation about the customer data that is now entering into force in Finland in November, and that's actually quite a big step towards the right direction, because it will enable the use of citizen-originated wellness data in the healthcare delivery process. and it will also enable the delivery of patient data back to the citizen through the various types of applications if they are actually certified to be of good enough quality. And the remaining challenge, of course, from the perspective of companies is that how this certification process can be made so that it is not too complicated and too expensive for the application providers. The last presentation today by Anna Korpela from Kela will address this Kanta certification requirements for health applications, which is very critical thinking about how this kind of services will emerge in the future. But I think the potential is very high. So this was about the background for this workshop, and already now I would like to thank a lot the presenters today and also all participants we have online today, and I hope we will have a lively discussion on these topics. And I suggest that because we are not so many today, you can make questions by raising your voice after the presentations, or you can also use the hand in the Teams user interface to express that you want to comment. So without further talk, I would maybe now give the floor to Mikael to guide through this workshop today and the presentations that we have. Thank you, and Mikael, you can continue from this.
Thank you, Jaakko. I must say I don't have too much to add. I think you made an excellent presentation on the agenda, and I would just say up to Terhi to first lead us through the new standard.
Thank you, Jaakko and Mikael. Thank you for the invitation to ask me to talk about this standard project we have just had, and this standard we just have published during the summertime. I will close my video and share my slides next. Maybe not this way. I choose to have this way. I guess you can see my slides now.
Yes.
Okay, so as you can see here, I am a senior health tech and digital health specialist working at the Lapland University of Applied Sciences during this fall time. A little bit, I think this presentation of mine serves as an introduction for this afternoon too. So I wish to share you some background what comes to mHealth and mHealth apps. I start with short history, because since the publication of the first mobile app store in 2008, the world has experienced a fast-growing market for wellness, health, and medical apps. So here you can see some 3 years what has happened during the 2010, 11, and 12. In 2017, there were over 3,000 of these types of apps available on major app stores, according to one report. Nowadays, maybe around 500,000 or even more. Some of these apps fall under medical device regulations, most do not. These so-called wellness apps are often promoted directly to consumers through app stores without going through any formal evaluation. Most of early apps were single-use mHealth type. These focus on single purpose for a single user, for example, exercise or weight loss apps. Social mHealth draws upon the social capabilities of mobile technology, including support, encouragement, or a sense of competition sourced through peer or social networks, for example, Diabetes Forum. A bit more complex is integrated mHealth, which links apps and devices with the formal healthcare system, typically via an electronic health record. Nowadays, though, we are moving to complex mHealth, which means data mining using algorithms to analyze data collected via mobile devices to deliver insights for individual health management purposes. Also, data analysis oriented towards improving public health responses like different risk profiles. Today, in most cases, the mobile app is the focal point within an ecosystem of devices. The app constitutes the center of a network and can be connected to wearables and tracking sensors, medical devices, electronic health records, or health data aggregators. As you know, app like magnifier in your smartphone can be a medical device depending on its intended use or purpose. Concerns about the quality and reliability of apps has been present since the first steps. Many are still being published with inadequate information for user or evidence to support clinical claims. The European Commission published recently the study regarding safety of health, lifestyle and well-being apps. The overall conclusion of this study was that at present no safety incidents concerning wellness or health apps that do not fall under the medical device legislation can be found in public sources. Based on the report, this does not mean that safety incidents with these apps do not exist. A number of reasons for underreporting have been identified, which some of them which you can see in this slide. The types of mobile app, health app publishers have increased in diversity. Among them nowadays also bigger actors like medical device companies and healthcare organizations. Yet though, over 50% of apps is downloaded less than 5,000 times. Among the key adoption barriers behind the current situation are a lack of clarity on mHealth certification, lack of reimbursement mechanisms, and lack of awareness of mHealth benefits among both health professionals and patients. Success factors for high download numbers are high patient ratings, frequent updates, connectivity to medical devices or sensors, and extensive clinical evidence. Healthcare providers want the reassurance that apps they recommend to patients will be safe, reliable, and effective. These 6 questions are typical and restrict healthcare professionals to prescribe or recommend any apps to patients. First is the amount of apps. Second is recommendation and prescription system. How should I act? Then the third one is the regulation, which is very strict. Then privacy, security, and then this reimbursement system, like who pays the app. And then this responsibility question, who is responsible one if some incident happens when using app or when my patient is using app. Patients indicate that sheer number of health apps makes choosing them confusing. They are suspicious of health apps because they don't know who makes them and prefer face-to-face consultations for that reason. So, who would they trust to recommend health apps? Australian consumers said they would trust a Google search and the App Store least. and cheapest most in recommending apps. In reality, however, they are mostly forced to count on App Store reviews with this question. And Australian doctors in this same study mentioned that they lack a trustful source and knowledge of effective apps. And for that reason, they are not willing to recommend apps. Here in this picture, you can see these, on the left side, you can see these years, and this means that how many years you have been in your profession. So it seems that these people who have been working for over 30 years, they would recommend apps more rarely than the younger ones. Many countries and organizations have health apps assessment frameworks and app repositories that meet locally defined requirements, even certification systems. Building these has not been an easy task. These activities are important for any app developer who want to promote or sell their product to or through providers of health and wellness services. However, the cost of responding to different extensive sets of criteria and different evaluation protocols in each country or organization is a barrier for app developers wanting to make their products available in multiple markets. It's also a problem for those evaluating apps and maintaining libraries of health and wellness apps. The European Committee for Standardization announced the start of the project Quality and Reliability of Health and Wellness Apps. It will help to establish a common framework across Europe or across even globally for the development and evaluation of these apps, giving users and health professionals confidence that the apps are fit for purpose. This document has been developed by a joint SEN and ISO project team with 60 members from 14 countries holding weekly team meetings. This document provides quality requirements and health app quality label as ways for app manufacturers and app assessment organizations to communicate the quality and reliability of health apps. To those not so familiar with, there are some key principles in standards development. Request comes from industry or other stakeholders such as consumer groups. Typically, an industry sector or group communicates the need for a standard to its national member like SFS in Finland. Standards are developed by groups of experts from different countries that are part of the larger groups called technical committees. These experts negotiate all aspects of the standard, including its scope, key definitions, and content. The technical committees are made up of experts from relevant industry, but also from consumer associations, academia, and so on. Developing standard is a consensus-based approach, and comments from all stakeholders are taken into account. A technical specification, which we are talking about now, approaches an international standard in terms of detail and completeness, but has not yet passed through all approval stages, either because consensus has not been reached or because standardization is seen to be premature. Input for the standard or technical specification, I should say, was gathered from surveys, interviews, and review of existing standards and health app assessment frameworks, like HL7 Consumer Mobile Health Application Functional Framework, which is even mentioned in this technical specification. 4 working drafts, have been commented on by the wider membership of the SEN and ISO working groups and their respective national bureau committees. The quality requirements and health app quality score calculation method, which you can see in Annex P, has been developed with a Delphi consensus study in which 90 experts from 8 stakeholder groups and 6 continents participated. So this was built like maybe you can say in two and a half years, and this is really published now. You can find this from your standardization organization webpage. Outside the scope of this document are guidelines to comply to the medical device regulation, as well as other related standards. Here we are talking about concept health software also, which includes software for medical use and software also for other health use. The total life cycle of health apps is covered. This document provides quality requirements for health apps and defines a health app quality label to visualize the quality and reliability of health apps. Here you can see part of the contents of specification. Chapter 4 is about health app assessment process itself. And again, the contents of Chapter 5 dealing with quality requirements, which are grouped in you may say in 5 groups: product, general information, health and safe, easy to use, secure data, robust build. The specification proposes a set of 18 questions for app developers and manufacturers. Based on the answers and evidence provided, the health app qualifies for an app quality label with a score on these four top topics, which you can see here. Each question has some purpose which is defined at the specification. So this is from the specification: label content, requirements level, color coding, filtering, or app assessments. The health app quality label, which is defined in Annex A, has been inspired by EU energy label that is also used in more than 50 countries outside Europe. The questions on the label with its color code support health professionals and users of apps to better select apps or easier. The 2 normative annexes provide requirements for the specification for the health app quality label in Annex A, and the calculation method, which you can see in Annex P, that shall be used to generate the quality score information that is displayed on the label. The document also contains a set of informative annexes, which you can see here in this slide. Annex G, for example, covers a range of ways that the specification can be used by different stakeholders throughout the life cycle of health app. At some repository or app store, the app label could look like this. This is just some imaginary example. By clicking label opens up a pop-up window with all label information in it. Here you can see some examples of questions which are pointed to the developer, and also the evidence which is needed concerning this question. Annex B is about health app score calculation method. First, you check that all questions identified as required in table B1 are either not applicable or have been answered positively. If this is not the case, then no label or quality score shall be provided. For each aspect of quality, these four ones: healthy and safe, easy to use, secure data, and robust build. Take the sum of white values in the table P1 for all questions that have a positive answer or are not applicable. This total is quality number for each aspect. Then use table B2 to determine the quality score from A to E that corresponds with the quality number for each aspect of quality. Multiply the quality number for each aspect of quality by the white provided in table B3 and sum the values to obtain the overall quality number for the health app. And then use table P4 to establish the overall health app quality score that corresponds with the overall quality number for the health app. The set of answers to quality requirements questions excluding evidence provided to enable app assessment form the health app quality report. The health app quality report can be made available to potential customers and users of health app to enable informed decision making. The health app quality evidence pack is the set of evidence that shall be made available to health app assessment organizations to enable the assessment process. The health app quality label enhances transparency concerning the app. mHealth Hub project evaluated some time ago 24 active assessment frameworks in Europe, one of which was earlier version of this technical specification. Also, one of them was ORCHA, which already has a review service based to this standard according to web page of company. But we will hear more about ORCHA after my presentation. Also, one was the evaluated ones was a governmental German DiGA. Which is law-based reimbursement system for app prescription in Germany. DiGA must have successfully completed the assessment leading to listing in a directory of reimbursable digital health applications, so-called DiGA directory. But this is also something we will hear more about when Mikael has his presentation. So this is my message for you today. I'm willing to try to answer to your questions, but I also would like to tell that to let you know that this upcoming training day about health apps trends regulation and assessment in November this year. So thank you. Happy to answer if I'm able to.
All right. Any questions from the audience? Also, feel free to post them in chat if you're able to. I noticed that for some reason I'm not able to access the chat, at least on my PC. I may have access to that on my mobile, so Teams has apparently had some updates. But anybody brave enough to ask Terhi a question? I'll start. I'll ask Terhi, do you know the cost of the standard if somebody would be interested enough?
Yeah, good question. I was checking it. It was, I don't know if I remember this right, but 180 in SFS maybe. Yeah, you will find it there. So just go to search field and put this number, and then you'll find it. This is not any. This is just something I remember, but it might be wrong.
That was the easy, quick question. Then I have another one. Do you have any idea whether we are likely to see those kind of labels in Apple's or Google's app stores for health apps?
I hope so. This is the target of our work. Those bigger ones, which I showed in, which you know already. This is something something we are targeting, but this is also there is a need to work for that in Europe and in national level too, like we have been discussing here with in June when we had this meeting held by Social and Healthcare Ministry and others. Yep. There needs to be a system. So all this what is included in this afternoon's program. We wish that this standard would be the tool for all of those. And also, just to let you know that we get some good comments during the final vote, and for sure there will be a new version of this, like with other standards too, like they renew them after every 3 years or so. But we decided to publish this, maybe because of this COVID situation too.
Yep. Very good. All right. Any other questions, discussion? If not, then let's move on to the ORCHA model and Tim Andrews from ORCHA. And I originally asked ORCHA to be present in our discussion because they have really good experience starting from the NHS of setting up a set of requirements and then balancing that across willingness of companies to participate to fulfill those requirements. So take it away, Tim. Thanks for being here.
Oh, just checking you can all hear me.
Yep.
Right, I'll just share my screen. 2 seconds. Right, you're all able to see that?
Yeah, in draft mode, so not presentation mode, but anyway.
So that now. There we go. Okay, well, hello everybody. Thank you so much for inviting us along. I'm Tim Andrews, Chief Operating Officer and co-founder of ORCHA. So I've been on ORCHA's journey for almost 6 years now. So coming up to our 6th birthday in about a month. And so we've been through sort of navigated through all of the many of the things that were discussed in the last presentation. I think actually only haptique, which I think appeared in one of the slides, sort of predated us. So I'm just going to quickly set the scene with the digital health challenge, and some of this has already been discussed, but I think it's worth reiterating. And you know, actually, one of the things that's been interesting about the COVID situation is that people have talked about the accelerant effect it's had on digital, and I think that's absolutely true. But certainly in the UK and you know, from our work across the world, this seems to be quite consistent. Actually, one of the things that COVID really illustrated, I think, to healthcare systems was that whereas prior to the pandemic, digital health was something that people could get to at a point in time, like all innovations. It was, yeah, we'll get to that. It's, you know, it's got some potential, but it didn't really have any great kind of impetus. When the pandemic hit, there was the obvious, oh well, let's go to digital health. That will help us out a lot. And I think what many systems found was when they kind of went to hit that digital health button, if you like, they found that they didn't have the tools and the systems and the approaches in place to actually take the advantage of that. And so I think one of the things that we've been sort of advocating for many years, which is that in order to make digital health work, you've got to really kind of build the infrastructure. You've got to create the systems and the processes, etc., to make it work, really came home in the pandemic. And actually what typically, you know, we observed certainly in the UK was that as a result, digital health did expand, and healthcare professionals particularly kind of embraced it, but they did it almost in a way that was kind of unregulated, informal, not governed, and there was a whole load of issues with that, which means that possibly doesn't sustain in a non-pandemic world. It was something that people were prepared to do because they absolutely needed to do it. So I think the issue still remains that healthcare systems now need to kind of learn that lesson and really put those systems and processes in place. So, we identified some time ago, the key main barriers, and I think they sort of remain consistent today. And the first of those is trust. And we heard earlier, about the new ISO standard developing, which is a real, addressing that kind of issue. But we know trust is kind of one of those key foundational challenges. And I suppose with that, actually, although it's listed as number 4 on this slide, comes governance. The two sort of go hand in glove. How do we know that the products are safe, effective, in all of the myriad array of things that, in a digital health context you need to worry about? And then how do we ensure that they're governed, we have the governance in place to ensure that we use the right ones, we know what's going on with them, we can monitor what happens when they change, etc., etc. So trust was really the foundation. That's where ORCHA kind of was born, really, because we knew we needed to address that particular issue, and that's where our kind of assessment accreditation kind of work started. I think awareness was a major issue back in the day, and I think awareness and accessibility also go together in a way. Now, for me, what that means is that actually it's quite often difficult to find products on the major distribution channels, which is obviously the app stores currently. If you type in some quite common product, healthcare conditions, what you get back is actually quite limited. And so what the awareness point is there is that actually those algorithms that drive those app store systems aren't the best at finding, for example, dementia apps or dermatology apps, and you can quite easily kind of find your way being navigated away after maybe 5 or 6 different search results to something completely random that has nothing to do with that, and that kind of limits people's kind of awareness and ability to access these things. And for healthcare professionals, of course, it's just not a reliable place to go to kind of try and find products to meet a particular patient or client's needs. And then the other one that actually isn't represented on this slide, but I think is really critical, is and it goes to that point I made a minute ago, is the systematization. So actually having the systems in place to make digital health a practical part of the armory of for healthcare professionals and healthcare providers. And for us, that basically means mimicking to a large extent the way in which other therapeutics work, and particularly prescription drugs, and having the same sort of systems in place. And so we will talk about formularies, digital health prescribing solutions, etc. So we kind of talk, whenever we go to talk to healthcare systems, national, pan-national or local, we talk about this sort of model, which is the 5 steps to achieving that kind of systematization and integration of digital health. So step 1 is getting over that trust and making sure that that the products you're going to engage with are okay. And there's a range of different ways in which that's achieved, and we've sort of seen some of that with the ISO work. Again, governance kind of could appear anywhere on this list. I typically would put it number 2, because then it's about, for a healthcare system, how do you make those how do you turn that trust into practical kind of processes and approaches that basically give your healthcare professionals the permission to engage with digital health and to utilize them in core things like care pathways and etc. Then awareness still is a key issue. So then making sure those solutions are easily accessible. For healthcare professionals, that's about creating formularies, and for for end user patients who are navigating there under their own steam, that's about producing libraries, or similar resources that they can easily and intuitively use to find products. Systematization is then the next one, and that's about basically ensuring that all of this, all of the way in which digital health is integrated into a healthcare system is intuitive and just part of the way in which those systems work. And so we had some great examples in the UK where there were some national procurements of digital health products, around diabetes prevention, weight management, and others, particularly pre and post COVID. But actually, when it got down to the ground level, it was how are we actually going to get these products out to patients? Literally, are we writing on a post-it note, please go and download this product, and here's a code to import? It just wasn't practical. And one of our clinical advisors, it was part of our clinical team, used the example of, we don't, when we're prescribing drugs, just pick up a box of pills and shake them at a patient and say, these are the ones you want, off you go. We prescribe, and the same should be true really of digital health now. And then integration. So having got those foundational steps in place, the trust, the governance, the place to go to find the products, the ability to actually then interact with those products and get those to patients safely, what you then need to do is say, well, where do these products best fit? Where can we make most use of them? And so that's about thinking about digital care pathways and integrating digital products into those common pathways, or toolkits for particular care settings such as primary care or maternity, etc. So those are the key elements. And then, of course, finally, and this is where kind of governance comes back in, we have to address remuneration and how does all of that get paid for, and how ultimately do those digital health tools become sustainable and actually become reliable, because unless there are commercial models, and essentially prescribing is probably the key one, that support those emerging organisations, those tools are really not properly sustainable in the long run, and therefore that presents its own governance issue and risk. So there are a plethora of emerging standards, as we've heard about already. And we talk about accreditation as a system rather than as a model. So what I'm trying to illustrate here is that there are three sort of primary ways, currently at least, that these accreditation processes and standards are actually put into practice. So you either have a standards only approach, where there is literally a standard published and people are told, there you go, you use that standard however you see fit to organise and govern whether you think a product's okay. So that's the approach currently being taken in the NHS through NHSX's DTAC. So they've published that as a standard. They don't do any assessments, they don't coordinate the assessments centrally, there's no central repository of products that have gone through that process. It's left to local NHS bodies to undertake those assessments, or alternatively, and as is mostly the case now, they come to ORCHA for us to undertake those assessments on behalf of many different NHS organisations, so they can just do it once rather than duplicating the effort. The ISO, I think, is an interesting one because it's sort of, obviously it is a standard in its own right. It's a standalone standard that can be used by individual organisations as they see fit. But we know that what's coming down the track with the ISO is probably a certification scheme, which will basically start to coordinate the use of 82304 in the real world. And that probably positions the ISO with the certification scheme, something that's more akin to a sort of what we'd call a centrally coordinated delivery model. We're working with a whole number of partners in the US to, and it's pretty much developed in its beta form to create a US digital health assessment. Again, that's likely to be something that's centrally coordinated with a group of organisations across the US sort of taking that kind of ownership and coordination role, because there's a vacuum there left originally by Haptique, then followed on by Exertia, etc. That we're where a practical assessment for the US is necessary. Now, there's a great read across actually between the ISO and that US digital health assessment, and many of the others I'll reference now. Other examples just quickly are the digital mental health assessment standard, which we've supported the development of in New Zealand. That's likely to end up a centrally delivered model through the via the ministry, but it might kind of go on a journey from centrally coordinated to centrally delivered. The assessment that the Dutch mental health organisation GGZ and Mind do, that we support the delivery of, which is centrally delivered. They do that assessment kind of on behalf of their wider membership of mental health organisations. Obviously, the DiGA, which we're going to hear about later, which is a centrally delivered model, and the emerging Nordic baseline review, which Anders is going to mention later after me. Again, that's also envisaged to be sort of centrally delivered. So you can see these different approaches. And the point about the delivery reference to that is that it does make a big difference, and organisations who are designing these schemes really need to think about how those schemes are going to land in practice. So one of the challenges that NHSX in the UK has faced, although ORCHA kind of mitigate it to a large extent, is this issue about duplication of effort. So actually, a product might be assessed by an organisation in Birmingham, then an organisation in Bristol, then an organisation in Bath, just to use all the Bs, over and over again to the same standard. So it's a waste of time for each of those three organisations to do that assessment, and it's a waste of time for that product owner to have to respond to those three different assessments. The other issue is that it's likely that each of those organisations will interpret that slightly differently, and at the minute there's no central, because there's no central coordination, there's no central interpretive guidance provided. So there's some real challenges with just a standards only approach. On the one hand, it appears to be actually it's good for a scheme owner because it's very light touch, but actually in practice out there in the real world, it doesn't really achieve anything. On the flip side, the central delivery model is probably the most efficient for a system, but it can also get bogged down and not and therefore not deliver the pace and scale that's necessary. And I think other issues just to know, and this can be true of any of these different models, is things like the issue of keeping on top of assessments. So in the standards only approach, it's the responsibility of the person who's used that standard and satisfied themselves that a product meets that standard to ensure that they, as that product changes, they keep on top of that. And actually, indeed, as the standard changes, if the scheme itself is updated, they would, be required to go back and reassess any products that they've currently got based on, the new scheme rules. So that's quite a big burden all around. A centrally delivered model can actually coordinate that much more effectively, but again, only if it's delivered in a way that's practical and agile. So the bit that was on the slide that said the ORCHA model, I thought this was probably the one that gave you the best visibility of that. So ORCHA build assessments in very much in the way this slide illustrates. And so we call it the layering principle. So you basically have a lot of, sorry, I've got dogs running around in the background here, so I do apologise. We build things, as I say, in this layered approach, and everything starts with an ORCHA rapid assessment. So that looks at a product, key functions and features, and that sets a scene for what the product, what we need to look at up the sort of upstream or downstream of that initial rapid assessment. The baseline assessment then covers a huge amount of the standard territory, as it were, of the digital health assessment world. So a huge amount of data privacy. We look at usability and accessibility in a range of ways, and we look at a range of clinical assurance things like evidence and professional engagement, etc. Now, then what has happened is different schemes have sort of been built off the back of that. So if you take the ISO as a good example, there's a strong core of, there's a massive overlap between the ORCHA baseline assessment and the ISO, and that's really beneficial because it means that when we've done the ORCHA baseline review, if somebody wants to then get the ISO certification, they only have a little bit more. Well, they have a bit more to do, but it's a big proportion, probably 60% of the ISO has already been covered in the baseline assessment. And if they, for example, have then achieved that ISO certification, you will see that they've got a long way on the journey to getting an NHS DTAC certification, because there's a big overlap there, and so they'd only in that case have one other element that they would need to build to have assessed in order to get their DTAC assessment, and so on and so on. And so as you move from one major scheme to another, the burden for a developer gets less and less, because there's more and more information that we've collected that overlaps with the next scheme, etc. So hopefully that makes sense. And of course, what the benefit of this is for those organisations who use ORCHA to deliver their scheme, it's the same thing. It's the other way around. So if you are in New Zealand and you're a health navigator, one of the things that you can that is very attractive is that we can immediately say to a population of 400 or 500 of the main digital health providers, do you want to get your New Zealand assessment certification? And actually, you only need to do this one additional thing because you've already got NHS DTACs or ISOs, etc. So that's the way in which the ORCHA system works. As I say, it all starts with the baseline review. I'm not going to go through that in detail because we're going to be out of time, but basically the key thing, and what's, I suppose, novel, and it started with the ORCHA baseline review, was this fusion of technology and human assessment. So sometimes people think that ORCHA's use some sort of automated assessment approach, and we don't. Everything that we look at, certainly from a compliance perspective, is looked at by a professional assessor. But we use technology in a really clever way to ensure that there's a huge efficiency in the way they do that, and we can use data techniques and algorithms and AI, natural language processing, etc., to provide some checks and balances around this. What that kind of looks like sometimes is this kind of model where you have on the far left hand side the area where we're collecting as much information as we can automatically collect from various sources. We're bringing that into our system and running that using data enrichment techniques to filter out, refine and improve that core data. And then it goes through the kind of human assessment side of the equation in the system. And all of this comes together to allow us to create the results of those different assessments, and also multiple different front ends, which I'll come to in a second. Well, come to now, in fact. So quickly, the other parts of this is, okay, having an assessment's great, but that's only one part of the story. You then need to publish the results of the assessment. So this is where we talk about digital health libraries, hubs, and crucially formularies. So in most, say in the UK and in different areas like Canada where we're working now, etc., what we're seeing is the kind of evolution of a central formulary. Often that's a national formulary with local variants in different provider organisations, where they build off that central formulary, but then they create their own. These are the ones that we're specifically going to use within our local context, and that goes back to that integration piece that we talked about earlier, where you choose that's the product for me in the diabetes pathway, for example. I'm not going to mention app matching because I'm conscious of time. I think I'll just emphasize that what's most important in all of this, I think, ultimately, to really supercharge digital health in healthcare systems generally, is healthcare professional activation, and getting them as our real, drivers of the digital health revolution. And in order to do that, you have to address these 5 things that healthcare professionals have told us over and over again that they face. So trust, we've talked about. Governance, which in a healthcare professional context is, am I okay to do it? Have I got permission? Familiarity is, what's the product? What's it going to do to my patient? Is that okay? Systematization is is what we talked about. Is it easy for me to do, or is it going to take me too much time? You know, they're busy people. Then benefit. How will it benefit me? How will it benefit my patient? How will it benefit my organisation? And so in our professional systems, we have solutions to all of those things. You know, the familiarity, we have an academy that trains people on, you know, different aspects of digital health. The systematization is our prescribing and recommendation solution, and that's also supporting the governance and trust side. And that's it. A bit of a whistle-stop tour. Loads I could have got into, but I'll just stop there, and happy to take any questions if there's any time.
There is indeed time for some questions. I think we are 10 minutes ahead of schedule, so.
Oh, there you go. I was rushing through for ahead of time.
Okay, I might ask something. It's Jaakko from VTT. I was maybe missed in your presentation, but did you specify sometime that what is the process, how application developers will enter your process of assessing them?
Yeah, so it's a really good question. I mean, we provide. I mean, actually, when ORCHA was set up, we didn't envisage that assessment would be the way in which ORCHA would kind of make money and survive. And actually, it was only when we were ultimately approached by the NHS Digital and said who were trying to run that national scheme, the original, probably the first big national scheme that was in development, to do it, that we sort of ended up going down that route. So we have two primary accreditation or assessment clients. So one is those national scheme owners like NHS, it would be in those days NHS Digital or the New Zealand Ministry, etc. Or it's developers who are wanting certification through a particular scheme like the ISO or the DTAC. One of the things, as a result of that, one of the things that we were really clear about straight away was that we wanted ORCHA to be accessible to every developer without having to pay. You know, we don't think it's reasonable that that only those who can afford to be showcased in the ORCHA system are the ones that do get showcased. So the ORCHA baseline review is free to any developer, and that's always been the case, and that's important because that's really the entry route into everything to do that ORCHA does. So the only thing that developers really pay for is where they specifically want ORCHA to provide them with a certification against one of these schemes, so the DTAC, the ISO, etc. And the way in which, and that that's because those schemes have merit, which the developers themselves will have evaluated and believe it's important for them to go through. And from that point onwards, it's very simple. We have what we call a developer account. Everything is governed through that. So the developer can either pay as you go, so they can pay on an individual assessment and say, I want, for example, my DTAC assessment doing, and they will have that. The problem with that is, and that's why most people don't do this, they will then immediately have to come back and have it reassessed as soon as they've changed their product, and obviously potentially if the scheme changes. So what people tend to do, what developers are more often doing now, is they're buying a subscription service to manage their certification. So they can either do that for one scheme, such as a DTAC, where they pay a monthly fee basically, and that gets them their initial certification, and then it maintains their certification every time their product changes or every time the scheme changes. Or they can buy that subscription for multiple schemes, so they can buy it for 2, 3, 4, 5 different schemes as well. So that's it. That seems to be what developers are seeing as being the best way forward, because they want to manage that risk that if they have 2 major releases in a year and the scheme changes, that's 3 reassessments of their product or recertifications of their product, and so that they want that kind of risk managed. And for national bodies, they essentially are paying for us to manage the scheme, but they will usually set any tariffs or costs of being part of that scheme. So in the case of GGZ in Holland, they don't charge anybody for going through that. They undertake the assessment for free. I know the DiGA has a cost associated with it. When it used to be NHS Digital running the predecessor to the DTAC, they didn't charge anybody either. So they would pay us to do the assessment, but they didn't levy a charge. So there's different models emerging.
Okay, thank you.
So Tim, one comment I would really like to hear from you is the one that you have expressed in, for instance, Nordic Interoperability Project, when I've asked like what your experience is with NHS and really putting that balance between, okay, these are all the requirements we want apps to fulfill, and what is then the response from app vendors?
Yeah, I mean, I think so. What's been interesting is the evolution of, so the NHS have gone through kind of in that model approach. Of course, they've gone from central delivery to standards only, kind of on a journey. And there's inevitably with publicly funded healthcare systems, there's a degree of politics associated with that journey. But to be fair to NHSX, one of the reasons why they've sort of moved away from the NHS Digital, predecessor approach was it was slow and cumbersome, and there was a huge amount of frustration amongst developers about just how hard it was to go through that process, and could sometimes take 12 to 18 months. So the DTAC was almost a kind of reaction to that, and arguably it's become almost gone too far the other way and is a little bit too lightweight. And it sort of switches, and it delivers different frustrations for product owners, because they now face, instead of a long, cumbersome bureaucracy, they now face the prospect of having to do this assessment multiple times for lots and lots of different organisations. So I think that there's a happy medium, there's a middle ground, and in reality, to an extent for NHSX, ORCHA's existence in the UK mitigates a lot of that risk, because we cover so many of the local organisations in the NHS use ORCHA now, then we are the de facto central coordination for the DTAC scheme anyway. So developers can come to us and go, well, I know not every NHS body is going to accept my ORCHA certificate, but probably 70% of them are. And for the 30% that for whatever reason don't, I've already done all the hard work to get my ORCHA certification, so I can then just present that to those, additional 30. So that's, I think we would say that I think there's undoubtedly no argument that the most efficient scheme from a national perspective is a centrally coordinated, centrally delivered one. And the trick, of course, is to be able to do that with efficiency, and that's why we have this model which is designed to ensure that if lots and lots of different international organisations basically use the ORCHA, the ORCHA engine, they gain that efficiency between themselves, because they're sharing compliance data across the piece, and it just takes the burden off everybody. But there are all sorts of reasons, and the ISO is a good example, and the US Digital Health Assessment is another good example where sometimes there just isn't an obvious scheme owner within a territory who is going to do that. In the US, it could have been the FDA, but they don't want to. So you're always going to have an alternative model available.
Speaking of a regional scheme owner, Anders, do you have a comment?
Yeah, just to make sure that we also address a little bit of the topic of today's workshop, reimbursement models. I think I would like to ask Tim to kind of elaborate a little bit about what is the status in the UK when it comes to reimbursement models, and how does it actually work?
Yeah, so I think it'd be really interesting. Obviously, we've got the DiGA presentation coming down the line, so I think a lot of people are looking at that with great interest. I mean, in the UK, it's historic for the last, up until now, it's been very ad hoc, basically. So some products get commissioned locally or nationally, but there's no sort of central scheme or coordination for that. Actually, we're just doing some work now, or we're about to start doing some work with NHSX, looking precisely at what's the right reimbursement strategy for the NHS in digital health. And I think that will be a really interesting piece of work generally, that I think other people can leverage, because we'll look at kind of both the economic argument, what should be, because we also work very closely with the National Institute for Clinical Excellence in the UK, NICE, And of course, they're the gatekeeper in the UK for, drugs that come into the system. And so they'll do that hugely complex economic analysis to say, is this drug something that should go into the, into the formulary and be capable of being prescribed? And we're working with NICE and with NHSX to say, how do we do that for digital health? What is that process? It'll be a build. It's definitely going to be a build on the DTAC. So the DTAC will be a gateway to that, but it won't be the answer to it. And so things like the NICE evidence standards framework, or its adaptation, which we've essentially driven. And now we're working again with NICE to kind of reissue a new evidence standards framework based on those adaptations. That will probably be central to it, but with a much bigger focus on economic evidence and the ability to demonstrate a return on investment.
All right. Thank you, Tim, so much for all the insight. First, we heard from Terhi and also from you that, okay, it's really cumbersome for app developers if every B starting NHS Trust or every healthcare organization imposes their own certification criteria, and you need to describe your product always with bit different ways. Of course, you need to standardize that, but then of course you can't standardize it across Europe because we in the Nordic countries may not think that the NHS model is right for us, or the DiGA model might not suit us.
If I just want to mention one other quick thing, because I know just to link that back to the ISO. So for us, the ISO is a great. We were part of that program team, and it was a great team. And I think what they produced is excellent. I think what it can really support is that convergence, and that so that greater adoption of similar standards and approaches from area to area. Now, what we advocate is a very pragmatic way of doing that. So, in all of the places, whether it's Israel, New Zealand, Canada, America, Holland, the Nordics with Anders and the Finnish work we're doing with the ministry guys there and the guys in Oulu, the ISO is really kind of a consistent core that we will always present. And what that's really driving is convergence in action. So, it's a practical way to get everybody on the same page, but they don't all have to, they're not restricted by having to accept that 100%. So what we're seeing is typically a sort of 80% acceptance of the ISO framework. And actually, that's still really incredibly useful, because then, from a cascading approach, that means that for a product owner, they know, well, actually, I've already established this element for the ISO. That's going to see me through all of these different schemes. So I think the ISO's got a huge, will be hugely beneficial.
Yeah, we'll hope it sets the baseline, and then we'll see what we get on top of that. Tarja Pietiläinen has her hand up, so any comments or questions?
Thank you, Mikael. Could you please, Tim, give an example of who is paying whom in this reimbursement scenario? I didn't really get the concrete. I didn't hear where the money is coming and going, to be exact.
Well, of course, in the UK, ultimately everything is going to be funded by, public. The budget that funds the NHS. So the work now, although and people sometimes mistake the NHS for being, hugely coherent and cohesive, and there is just one central thing that works. And of course, it's in many ways 830 different NHS organisation bodies, under one umbrella. But when it comes to prescribing and drugs, for example, that is something that's actually managed largely at a national level, as I say, through NICE, and they will dictate which products can go into the NHS and which products can be locally prescribed. And it's envisaged that that's possibly for digital health reimbursement, that's probably one of the directions of travel there, certainly for therapeutics, that same sort of model will apply. Now, that won't work in the same way in insurance-based schemes or in private healthcare, orientated schemes where, there'll be too many individual, organisations making judgments about reimbursement. But I think what could be leveraged from that NHS model is the basis on which a product is evaluated for its economic value. That could then be reutilised by whoever happens to be the payer within the relevant healthcare system.
Okay, thank you. Now I got the idea.
Thank you.
And coming along, my presentation of DiGA is much more clear-cut in who pays whom for what. And then we still have a bit of question mark regarding our Nordic healthcare model. So I think now it's time to let Anders take the scene and explain what you have been up to so far. Thanks, Tim.
Thank you very much. I think that the presentation of Terhi very nicely addressed the challenges of digital health and the emerging market of digital health. And I think that Tim presented a possible solution for how to handle the emerging market of digital health. And that is kind of why the NIP initiative is there. And I will walk you through some of the thoughts behind why we did a Nordic initiative around this and where we come from, to understand that it won't be addressing the reimbursement models that much, because as Tim was saying, not many countries have come very far when it comes to that. So that's in the discussion for the Nordic countries as well, to take how they want to deal with that challenge. But I will give you some insights to what I'm working on. If you can see my screen, which is the most common used question in digital age. Do you see my screen?
Yes.
Yes.
Perfect. So I just want to give you a little bit of a picture of where we come from, this initiative and this project, because that's important to why we are doing this and also what we want to achieve. And the NIP project, which is the shorter form of the Nordic Interoperability Project, easier to say NIP, was initiated in 2018, and it is the result of a lot of Nordic discussions where smart people from the Nordics are meeting up at different physical conferences and putting their heads together with a Nordic agenda. And those discussions have been, multiple of them. And the challenge is that gathering smart people from the Nordics in a meeting room like that is quite easy. Making those people also agree that it would be very beneficial for everyone to work across the Nordics is also easy for everyone to agree upon. With smart people in the room, it's easy to come up with some ideas what to do about that. The challenge is just very practical. When those smart people from the Nordics are leaving that meeting room, they are all of them mostly going back to national, regional, or local responsibilities. Very few people have a Nordic responsibility. So then nothing much is happening on the Nordic cooperation until these people meet again on another conference, and then they're starting from scratch again, saying that wouldn't it be great if we could cooperate more. So this initiative was taken then to focus on less conversation and more action, and to have a focus on making cross-border health data and patient mobility into the Nordic reality, which is a highly ambitious goal. And it wouldn't have been possible if it wasn't for something I come back to. Just want to mention that this was started in 2018, based on some of these people from these meeting rooms putting their heads together afterwards, saying, let's do something instead of just talking. And then they took this initiative and invited me on board as the project manager for this. And we started out by collecting a group of stakeholders from the Nordics, Nordic healthcare region, representing both the industry, the pharma, research institutes, hospitals, etc. And some of those you will see on this slide. Now there are more organizations than supporting this Nordic ID. And as I said, it was highly ambitious, and it wouldn't have been possible if it wasn't for the fact that the Nordic Council of Ministers have already decided that by 2030, 9 years' time, the Nordics will be the most sustainable and integrated health region in the world. And they made a film in 2018, which is still to be found on YouTube, made by Nordic Innovation, where they presented their future patient called Sophia, who in this film is then traveling across these 5 countries and having her data available either for care purposes or for research and innovation purposes. So the goal was already set by the Nordic Council of Ministers, and we as a Nordic initiative is only supporting that and saying that let's do that. We're not challenging this goal. We say that this sounds like a really good goal to reach, but then something has to happen. And I'll come back to that. What we're working on is then also based on some of the reports coming out of the Nordic Council of Ministers and their organizations. One of them being the Nordic Health 2030 report, addressing more about the goal of 2030. The second one is the one in the middle called the Nordic Commons. That's a report coming out of ORCHA, which is also an organization under the Nordic Council of Ministers, focusing on research and innovation. And that report is actually addressing the huge amount of quality health data existing in different data lakes in the Nordics, but is also addressing that with modern medicine and diagnostics. We very soon will need bigger data lakes than what can be achieved within one country of those 5. So it's addressing the need of connecting the data across these 5 countries for research and innovation purposes, but also for personalized medicine. And the third report is then this report called Bridging Nordic Data, which was an initiative that we also pushed towards the Nordic Council of Ministers, which is then addressing the legal interoperability issues when it comes to the sharing of data in the Nordics. That report was done by Deloitte on behalf of Nordic Innovation, and it was presented first time last summer. And that report has a more practical angle to the legislative challenges. And also when we had a briefing meeting with the Deloitte, we also said, don't come back with a report telling us about all the challenges of sharing data, because we are quite aware of them. But please tell us about the possibilities within the current legislation. What kind of data and what kind of corporations can we have across the Nordics? And if there are hurdles and obstacles, are they due to legislation, or are they due to the interpretation of the legislation? And that report is then addressing the situation in the 5 countries, but also then suggesting initiatives that each of the 5 countries could take to make the sharing of data more easy. But then to go back to the first report, Nordic Health 2030, one of the things that report is stating is that the Nordic welfare model is not sustainable, focusing on the fact that in the 5 Nordic countries, we are spending approximately 11% of GDP on traditional healthcare, could be translated into sick care. It's money running into the system when you have been defined as a patient. But on the same time, we are approximately in these 5 countries spending 0.3 on preventative care. So in this report, which was made by the Copenhagen Institute for Future Studies, with a huge amount of stakeholders from the Nordic countries involved in the project, they have come up with the suggestion that we have to move towards a more balanced model, where we invest more in preventative care and less in the traditional healthcare, or at least invest more in preventative care to make sure that we don't have this same push on the traditional healthcare system. Hence, what is now called the 5-5 aspiration, that equation would be a little bit more imbalanced. And to make this happen, the report is pointing towards 3 areas where we have to work. One of them being that we need a new social contract with the individual. You and I have to be more involved in our own care, not only as a patient, but also to keep ourselves well and focus on preventative care. And here we see a huge potential in the digital health sector. It also states in this report that we need new ways of sharing data, not only between the healthcare systems, as we are focusing on today, but also between the individual and the healthcare system. And in this area, we also see digital health as a potential tool to make that happen. And then, which is very relevant for the agenda today, We need to see new business models that is also rewarding preventative care and also then perhaps preventative digital health care. And in this report is also painting a very nice picture of the balance of data sharing between the individual and the system, the healthcare system as we know it. And in this model, it's very balanced and nicely floating back and forth. But of course, we all know that that's not the case in 2021. This is the ambition for 2030. Because if we had drawn that picture in 2021, the individual would be more or less not involved at all. The healthcare data is being locked into the traditional healthcare system and being taken care of for us on our behalf. We are more or less not involved. So this is why the NIP initiative have been looking and working to see where could we make a change, where could we make a difference when it comes to working on a Nordic level to make this happen. And then based on the report, the Nordic Data or Nordic Commons report, we looked into the connection of the different data lakes in the Nordics. Is it possible to connect them? And we have now our work going on where we are looking into how to connect these existing data lakes, not by moving the data around, but perhaps to move AI algorithms around. So we're currently doing a pilot on that, where Finland, Iceland, Sweden will be involved to see if we can train an CE-marked AI algorithm on 3 different data lakes without moving the data. But even if that report, that Data Commons report, would be a success, it would only be addressing the connection of existing healthcare data in the traditional healthcare system. It would not involve the individual anything more. And that is why the NIP have taken the initiative for what we have called a Nordic Digital Health and Medication Platform. A solution addressing the problems that Terhi was addressing, but also based on the solutions that Tim was presenting. So by coincidence, we were at a presentation in Denmark where Liz, a colleague of Tim, was presenting the work that they had been doing in England with NHS and with ORCHA. And we knew at that time that all of the 5 countries had it on their agenda to find solutions for quality assuring digital health solutions and make sure that that came into play in the Nordic welfare model. But we also knew that none of the 5 countries had started developing any system by now. So we thought as a Nordic initiative, it would be better for us to take the initiative to see if we could come up with a common solution for all 5 countries in 2021, instead of developing 5 different solutions for this and try to merge them together to live up to the vision of 2030. So that is what we'll call the Nordic Digital Health and Medication Platform. We're also working on an initiative on how to make sure that data is being accessible for the individuals, but I want to talk about that. So let's focus on this digital health and medication platform. As Tim was mentioning, and Terhi as well, this is an unregulated market. And we would like to put the individuals, based on this report of 2030, we would like to get a new social contract with the individual and help them get involved in their own care. And then we also have to guide them towards the right solutions. Currently, as it has been mentioned, the only guidance we give to anyone who wants to be involved in their own preventative care or in the care process when it comes to digital health is to push them to Apple App Store or Google Play to find something that they think it looks fun. And the data collected and the effort they do will not come into play in the Nordic welfare model because there is no quality assurance. So based on that, we would like to help out to involve the citizens through the use of digital health by putting in play an evaluation system for the Nordics. And also through that, build a Nordic-wide home market for the industry. One of the challenges of digital health is that it's quite easy to develop. It's quite easy to launch, but it's difficult to get a business model behind that makes it live for more than some months. The solution might still be available on the different app stores, but it will not be any companies behind, so it represents a risk. So you and I can find a solution, we can start using the solution, we can collect data, healthcare data or preventative care data in that solution, but there's absolutely no security behind. So for that reason, we both need to do this for the healthcare sector to make sure that we get quality assured digital solutions into play, but we also need to do this to build a Nordic healthcare industry by giving them the opportunity to get a bigger marketplace than just one area or one region or one hospital. By common solutions in the Nordics, we could address this with a Nordic platform. So the goal of the initiative that I'm leading is then to unlock this power of digital health by establishing a Nordic-wide accreditation or dissemination service for healthcare apps, and then build business models for both preventative care and for healthcare. And here, this reimbursement models will be extremely relevant to see if we one day in the future can make doctors recommend or prescribe a preventative care digital health solutions, as well as one for a care process, but also then to establish this one Nordic market for startups. As Tim was addressing, and what I've been more and more aware of over the last 2 years when I've been working on this, is that the whole question of digital health evaluation is not about finding the right standard, it's about finding the right system. Tim has addressed that very well, so I won't go into details of that, but it was mentioned, awareness, accessibility, trust, and governance is extremely important. And we have to look at this in different layers. And very, very much when I talk to the different authorities in these 5 countries, the focus is very much on the top level or layer of this. What is the standard we should use to make sure that we have a good evaluation model? But as I tell them, based on the international experience that is out there, based on the frameworks that is there, based on the ISO standard, based on the different standards existing, we will be able to quality assure digital health solutions. So that's not the question. So within very short time, we can have a lot of digital health solutions that is approved, but that's not enough because we don't need a lot of quality assured digital health solutions. We need a lot of quality assured digital health solutions in the hands of the right people. So while we are focusing on evaluation and accreditation, we also in parallel have to focus on activation. What to do with the quality assured solutions when they have been quality assured, because that will happen. And then the big question is how to get this implemented into the healthcare sector in the hands of the doctors, the nurses, and the patients, and the individuals, to make sure that we have focus and spend time wisely when it comes to collecting data that could also be used for preventative care data. So this is what we've been working on since we got the support from Nordic Innovation, which is then the organization under the Nordic Council of Ministers. We've been focusing on, first and foremost, to focus on building the accreditation and review services, where we are currently been working for more than a year, based on the work of ORCHA and other international frameworks and standards. We've taken that as a starting point. We've been working with different workshops and stakeholder groups and different processes on looking into what could be used of those international frameworks in a Nordic framework that could be common for all 5 countries. And then also look into what could be interoperability requirements in such a way that within this region called the Nordics could be able later on to share data across the Nordic countries, but also across different health apps, or from health apps to health system, or perhaps from healthcare or from health apps to a preventative care data lake. That would be the first preventative care data lake cross borders anywhere in the world. And then we could do a lot of research and innovation purposes on top of that. But as I said, it's not enough just to focus on the accreditation part. You also have to focus on the dissemination and activation services. And to do that, we have to make easy access across the Nordics for the quality assured solutions. So currently there are work being done in all 5 countries on how to evaluate and perhaps also do pilots on evaluating some apps, but there's no much thinking on what to do with the solutions afterwards. What we are doing in this project is, in addition to build the Nordic baseline review requirements for what is a quality assured solution in the Nordics, also build a app store or a warehouse for the quality assured solution, so that anyone across the Nordics from the professional side could access that app store and download that to national platforms and national websites. And as Tim was explaining, the governance model will then of course be there, so that whenever an approved solution is being updated, it will be flagged in the system that it needs another re-evaluation, and that will then be flagged throughout the platforms in the Nordics that have taken use of a solution that coming from this warehouse. And then it's the question of how to, from a national perspective, how to make sure that this is being distributed either directly to the individuals to get them involved in digital health and in preventative care, or through the professional system through reimbursement models and prescription services. And that's what this workshop is all about, and all that's a discussion that needs to be taken on the Nordic level as well. Tim was explaining a little bit about the different layers that we have been building into the Nordic baseline review, which is then built on top of the international frameworks, so I won't go into details of that. Just very quickly at the end, address that where we're at now is that we have built, based on the ORCHA work, we have built a platform for the operative way of testing digital health solutions in the Nordics, platform to how to do that very easy and go through the process. We have built what is going to be the start of the Nordic warehouse and the governance model for the quality assured solutions, to be found by either national organizations, authorities, or then of course local or regional authorities. We don't think this should be open to the public, that for the national authorities to decide how they want to distribute it out in the Nordics, but it should be available for the national organizations to find the solutions somewhere. This also gives the opportunity for the app developers to have a Nordic-wide market by being then a part of this Nordic App Store. And we have, of course, app cards or information cards for each of the solutions to make sure that it's very open, to find out how it has been evaluated and what is the score and what is then the comments around each of the areas it has been evaluated on. So that's currently what we are working on in the Nordics. And as a great good initiative that we see that we would like to have digital health, quality assured digital health solutions into the hands of the right people.
Thank you so much, Anders. Did I get it right, your third last slide or fourth that mentioned the application portal? Is that live?
It's not live as such. The platform is in place behind the scenes. We're going to have another meeting with the Nordic Council of Ministers and Nordic Innovation on Thursday, where we're planning for a phase 3, and one of the goals of that is that we will find the funding or get the funding to open that as a Nordic-wide platform for the approved solutions. Currently, the 5 countries are very similar when it comes to the maturity of how far they've come when it comes to digital health evaluation. Finland has the pilot going together with ORCHA, among others, where they want to test 30 apps. Norway want to have a pilot where they test 3 or 4 apps. Denmark has a national platform in place where they have decided to cooperate on the Nordic level with us. Sweden is currently moving towards doing a pilot where they want to do evaluation of some apps, but they have no thinking of what to do with the apps afterwards. And what we want to give them as an opportunity is use that as a carrot for the developers, so that if they go through that pilot, we at least can make sure that they have a Nordic-wide distribution possibility through the Nordic apps.
Yes, please. I'm an app developer. I like carrots. Terhi, please.
Thank you, Tim. This was interesting presentation, and also, I mean, Anders, and also Tim's one. I would like to ask just short, tiny question. What do you mean with MDD, MDR aligned with the last slide you showed, what it means.
That one.
Aligned with MDD, MDR. I know what they are. I mean, these, the regulations, but what you mean in your system under MDD, MDR? Do you mean that the devices like with the DiGA model, they are medical devices, what they have in the loop? Or what do you mean by that, Anders?
Want me to answer that, Anders?
Yeah, Tim, you can start.
Yeah, so for us, what we try to do is to say that we don't want to create rework if something's already gone through a proper medical device certification process. So basically, class 2 and above, you know, with a certification with a notified body. As far as possible, what we try to build into the assessments that we look at is that we won't look behind that because there's been an established organisation that's, you know, done certain things. So and that's not always 100% easy because, and actually we've just been doing some detailed work on medical device regs for this reason, because it's not always 100% clear what a notified body 1 does versus what notified body 2 does.
Yeah, for sure.
Things. So it's where we have a very clear standard, let's say around security, it would be nice if we could say, well, actually, we know that every notified body for an app that is a software as a medical device will have looked at security in this way, and therefore we don't need to look at it again. But unfortunately, that isn't quite the case at the minute. But so what we definitely don't do is we don't seek to kind of check whether the CE marking is appropriate or anything like that. If there's a CE mark by a notified body, then we'll accept that as being, you know, absolutely fine, and there's no attempt by
re-evaluating.
Re-evaluating. In an ideal world, and I know the ISO really tried to unpick this a bit, but it was beyond the ISO program, to be honest. What we need is just more consistency in the interpretation of MDD and MDR generally, and we need more transparency, in my view, from notified bodies and from competent authorities as to how, you know, where they draw a line, particularly in relation to software as medical device. So because I think if we knew that, if there was a really clear interpretation for each of those areas, evidence, security, etc., then there would be a huge amount of rework avoided with these additional schemes.
Yeah, we had a lot of discussion. I think Mikael remembers. We were discussing a lot with this item in June when we had this meeting, a discussion, a roundtable meeting or whatever in June, held by Ministry of Social and Healthcare. But and even with the DiGA model, there is the thing that they need to address there, because in there this program is built with medical devices, but class 1 and class 2A. But now with MDR, the word is different. So most of the like you said, Tim, most of the apps and software is at least 2A, even more. And how they handle with 3 ones, for example. I mean,
exactly. Yeah. And I think we've got a session actually later on this afternoon, and it's actually it's called the Digital Health Assessment Assembly. And we bring together all of the teams that are working on different digital health assessment schemes around the world that we're working with, and the topic is evidence, and that's a classic example for us where you have the NICE evidence standards framework, which could become the foundation for how evidence is treated in the digital health space. But at the minute, it's not clear whether if you went into a medical device process with BSI, they would require you to have an RCT. But if you went into that same process with TUVSUD, they'd say a high quality observational study would be okay. And then you're in a scheme like like the ones that we're working on with Anders, where we would use the evidence standards framework, take that, and then similarly the ISO, which kind of has a slightly different variation on a theme. So just in that one example of many examples of that, some sort of interpretive convergence would be massively helpful.
Yeah. Okay.
And I must emphasize that digital health needs to be evaluated, and also the effectiveness has to be proven differently from medications.
Completely.
If we update our apps twice per week or twice per day, it's not the same as medication.
Industry doesn't need more load or burden with these assessment systems because the EU regulation is now so strict. So that's something we have to consider.
Terhi has her hand up also.
Thank you both.
Thank you. I'm coming back to preventive care. It was very interesting, Anders. Thank you. Now reflecting on the Finnish scene, most of the preventive action taken in this country is in the hands of associations, non-governmental organizations. I don't know about the other Nordic countries, but have you thought about involving like major national associations into this process when you come to the service and dissemination part of your work program?
Yeah, we have, because that's of course of huge importance. We have a very close dialogue with diabetes organizations or patient organizations for diabetes around in the Nordics. We also have a dialogue with the cancer associations, which are two huge patient organizations that will be helpful for us to gain and have the support from, and we have dialogue with them around that, because that's definitely going to be the focus on preventative care. Preventative care is really challenging, and as I addressed in the report, if we want to have a good balanced model in the Nordic welfare model, we have to have more focus on preventative care. But it's difficult because preventative care is a lot of things that don't happen. It's easy to measure the work done for patients because they have been defined as patients. But who should be paid for making people not sick, for keeping them healthy? And that's a challenge, but we definitely have to find solutions on that. And in that sense, patient organizations is a really important voice into that work and see how we can do that. And also just to address the difficulties of digital health, because what we are approaching them in the Nordics is to look into a layered system where the digital developers can themselves define whether or not they have defined their app to be very simple, just with advice, and doesn't need to have a full examination of all kind of things, or if it's up to a very complicated medical device where they have to have a medical device and CE marking as well, or something in between. And that will be up to the developers to find what level would they like to have their evaluation based upon. And some of those digital health solutions will then be defined as preventative care solutions. And then it will be easier for us to identify them, to discuss with them, but also then to take into account in discussion with patient organization or others. How could we make sure that these apps comes into play in a preventative care program?
If I just add one thing on the preventative care, one of the research programs we're running with Warwick University, which is just kicking off, is a deep dive into behavioural change apps that are promoting a behavioural, some sort of behaviour change, and we're looking at specifically what kind of things would you expect to see in an app that's promoting a behavioural change component, which is typically a preventative type of apps. What should that really look like using behaviour science and that kind of thing? And can I just mention one other thing, because it was remiss of me not to mention it earlier, which was, of course, one of the schemes that we're running is in Finland with the ministry and with the team in Oulu. I mentioned it briefly, and that's very much sort of taking into account the Nordic layer, but looking at what that should look like in a Finnish context specifically, and then testing that on the ground with the team in Oulu. So anybody who would like to get involved in, because we're at the stage now where we're actually starting to assess products just to test the scheme and see how it works. So anybody who would like to get involved in that, if you've got a product that kind of fits the bill, we'd love to hear from you, because we're in that kind of last stages of that first bit of that project. And I think the Finnish guys are making great strides in trying to unpick this, but also in a way that's consistent with what Anders and the team have been doing.
Just a quick comment. I would like to see mental health associations in this work. Many startups have experienced especially here in Tampere in Health Hub, that associations can be very conservative when it comes to digital tools, but they need to be involved, and especially speaking from the Finnish point of view, mental health is a key health issue at the moment. So it's driving patients into healthcare, so to speak, and they are really, well, many of the innovations historically have been developed in the non-governmental organization side here in Finland, and I think I recall that that's the case also in other Nordic countries. So good work.
So before further discussion, I would like to take this opportunity to train something new with these digital tools. So we are kind of now on a coffee break. So could we have some kind of a coffee break discussion if you would put your cameras on and we could see more of each other's faces. And Fredrik, I saw that you had your hand up, so you can have the first talk there. But if you're not in a hurry to go to a bio break or anything, then let's try this kind of a coffee break. Cameras on and free-floating discussion for about 5 minutes.
Yeah, hello. I was just thinking, is it mandatory to have MDR mark to be publicly reimbursed? For some products that will be floating between over-the-counter or medical device products. So there's a gray zone between the ordinary over-the-counter products and medical device products.
Yeah, I mean, I think, and it's interesting with the DiGA, the DiGA's gone, and actually the FDA sort of took a similar approach, and they used the medical device classifications as the way to delineate which products they were interested in, and they would take an interest in, and obviously the DiGA scheme has followed suit. That approach, I don't think, certainly isn't one that's discussed in the UK. So there isn't a preference or an assumption that you have to be a medical device you have to be classified as a medical device to be reimbursed. In fact, there's lots of products that have been nationally commissioned that aren't medical devices in the UK. I think it's a relatively arbitrary way to go. I think you should commission products because they're good and effective and deliver a value, and some of them may happen to fall into the classification of a medical device, in which case they will need, of course, to go through that process, and some won't. But we always use the example of two classic apps. One is Brush DJ, which is actually free, so it's not really a reimbursement issue, but Brush DJ that plays music for 2 minutes to encourage children to brush their teeth. It's a brilliant app and does a great job, in that very specific area. And something like FibriCheck, which is obviously an atrial fibrillation monitoring and diagnostic tool, which is a full-on medical device, and both of them are incredibly useful. Both of them have their role to play. Probably FibriCheck's the one that most obviously you'd think of would be commissioned, but actually from a preventative perspective, even something like Brush DJ might be something that somebody like Public Health England would want to encourage and possibly procure, and it's in no way near likely being a medical device.
Yeah, thanks.
Terhi, come on, camera on and just speak.
Yeah, well, I think there is the need for two types of models, just because these wellness apps, there is a need to assess them, because with this reimbursed model, I think they should be medical devices. And the other thing is all those libraries and assessed wellness apps. They should be evaluated and found somehow, somewhere. So I think there is. I think we discussed this type of things here in Finland. There were two ways of addressing the problem or challenges.
Yeah, if I could comment on that, I totally agree that also wellness apps or preventive care health, digital health solutions should also be evaluated, and should also be found on trusted sites, because they can be found on digital or Google Play or Apple App Store, but it's not guidance, no public guidance. And within the framework of the Nordic welfare model, we expect to be kind of taken care of by the public. That's one of the reasons why we have a model where we are willing to pay quite a high number of taxes that the public will take care of us. And I think that in a long-term perspective, I think that what is challenging in the Nordics with that model is, of course, the fact that technology is developing extremely fast, while political systems is very slow. And currently, it takes a very long time for authorities to find out how to use the digital health solutions. And why they wait finding the perfect solution, how to do this. Digital health is happening outside their windows, and it's happening in different parts of the world, where you and I, as individuals, can take solutions into use. We could share data, we could collect data that is being stored or being shared among others around the world without us more or less knowing. We have just approved the agreement in the beginning of using that app, and suddenly our data is shared. That could work well for you and I, because we get solutions that is helpful for us in our situation, but it's not the Nordic welfare model. So if we want to keep this Nordic welfare model where the public is kind of on top of and having control of how to use this digital health or health system, I think that they have to come on board very quickly on how to address medical devices of digital health, but also when it comes to preventative care data and preventative care apps for health.
Thank you so much, Anders. That is a perfect segue for me to go into the DiGA model, because some political processes take a long time, and I think it's beautiful what Germany have done, because they just couldn't be happy with their existing system and they needed to come up with something new. So I'm taking the lead now. Thanks for the coffee break. Let's try another one at the end of the session. Now to the DiGA Fast Track. This is not my presentation. This is from Health Innovation Hub from Germany, and it's actually from last year. I'll start with this and then I'll share some more recent numbers after this. Before going to the presentation, my really brief summary of the DiGA model is doctors can prescribe apps. Whoa. And the insurance company pays. Whoa. And the citizen doesn't pay, and the app providers are really happy. So this is something that we'd like to see in some shape or form in the Nordic countries as well. And what made this possible in Germany was that they realized that yes, healthcare is going digital. They realized that even before COVID, and they also noticed that in Germany, they were consistently lagging behind all the other European countries, or they were in the very bottom segment of digital health adoption. Everything was done with pen on paper, and they were so focused on data security and privacy and so on that the adoption of digital health was absolutely zero. And that gap that they felt that they have with the digital future that they need to come to was something that made it possible for them to invest heavily in this DiGA process. So this presentation has a few slides of Health Innovation Hub. I won't go into that because I don't know them so well, but let's start with the DiGA Fast Track. So it is, well, until 2020, there was no specific pathway for digital health solutions. So digital health solutions could theoretically be reimbursed like medications, or they could be reimbursed like supplies or medical devices, or they could be reimbursed as IT technology for a healthcare provider. But there was no harmonized way in Germany to do that. And now the DiGA gives you a harmonized way for a certain subset of digital health products. So they say that it needs to be class 1 or class 2A under MDR. And you can put MDD stuff there if it complies with those under MDD. And the intended use needs to be centered on the patient. So there might be a role for the doctor or nurse, but the main user needs to involve the patient, main use case. And it also needs to rely on digital technologies. There might be a hardware component, for instance, but there basically always needs to be an app also. It might be a mobile app or web app, but you need an app. And there are many different functionalities where you could use that in, but those are the main constraints. So it is still a subset of digital health. And this is the path, how it goes. So first you consult the BFARM or BFARM in Germany. They have some consultancy services, some of them are free, some you pay for. And then you make an application. And in the application, you have two parts. You have the general requirements. You need to prove that it's safe, it's of high quality, the functionality, you need to explain that and justify it. And also privacy and data security are under heavy scrutiny. So you need to provide a lot of documentation saying that, yes, we have taken all this into account and perhaps we have this kind of certification for our data security practices. And the other part is positive care effects. And these are divided in two parts. It might either be the medical benefit, so clinical efficiency, or it might be the structural or procedural effect. And that means that when somebody uses your product in a healthcare setting, it might, for instance, save time or make the process easier, more lightweight for either the healthcare professional or the citizen. And that is also considered positive care if you're able to prove that. So if you don't fulfill some of the general requirements, you drop out immediately. You need to go back and revise those. And for positive care effects, you have two alternatives. If you already have proof that your stuff works, you have validated it, and you can convince that it works also in Germany, and you also fulfill the general requirements, then you go straight into the DiGA registry. And that is where you're present and doctors can subscribe and you have a fixed price agreed with the insurance companies and everything works well. However, if you don't have proof validation yet for the positive care effects, there is another alternative, and that is the preliminary listing and a 12-month trial period. Because there is this chicken and egg problem, you can't get through evidence if your product is never used anywhere, and it's never used anywhere if it's not proven. So this addresses that specific problem. You get 12 months to get validation that your solution really works. So as you see here, the blue line, if you go to this preliminary listing, then continues with this. You set up plausible hypothesis and evaluation concept, and you try to get the proof that it works. And after that, you get into this standard care model. And during the first 12 months, the producer of the application can set the price of the app. And after that, there will be price negotiations, and then it might be higher or lower based on the actual validation that you get and on your negotiation abilities. So this GKVSV is, I understand, the kind of a consortium of the healthcare insurance companies. So you need to negotiate the price with them after the 12 months. But for the first 12 months, you can basically set the price and you are reimbursed based on that if the doctors prescribe your product. So these are the two proofs. First, the general requirements, then the care effects. And as said, care effects can be either these medical benefits or structural and procedural effects. And there is further specification available for all of these, mostly in German, but also some in English. So this is more details of the general requirements. There is CE marking, there is privacy and data security, robustness, user friendliness, consumer protection, patient safety, interoperability, quality of medical content. All of these you need to prove. And then the positive care effects. There are different paragraphs here outlining more the things that you can focus on. So you may have controlled trials, and those might be retrospective. So you don't necessarily need to start your pilot now, and might be prospective. So starting from now. And I guess you can also, doesn't necessarily need to be your product. If there is very similar product already out there, you can use their proof. Then the second thing about the structural and procedural effects and medical benefit. So again, what would these be? Medical benefit, reduced morbidity, increased quality of life, decreased mortality, decreased adverse effects, and structural, securing standard of care, so making it more coherent across places, coordination of care, make it easier, access to care, make it easier for different kind of demographics to access care, increase health literacy, increase medication adherence, for instance, or other adherence to treatment. All of that would be considered positive care effects, even if it wouldn't have any medical benefit that you can prove. And this is where you can get these proofs. So you have new kind of data pools. I guess they have this slide, so you can use real world data in this. So you don't necessarily need to go in a limited clinical trial. This is really the new part here. You can use your 12 months in a real world setting to get actual data, and that is even more convincing than if you would select a small patient group and try your product out with them. And there is a B-Farm guideline for DiGA with these topics, and last I checked it still wasn't available in English. And then there's pricing, and last I checked there were no real published information about that, but soon I'll show what are the prices for some of the preliminary or some of the permanently listed DiGA apps. And then this presentation also has examples of how could this then be taken into use. How would patients enroll with your app? How would they take it into use? So one example is that a physician actually writes a prescription for you, and then you download an app from the app store, and then you upload in the app some prescription, or you have some kind of other mechanism of sending that into the app vendor, and after that you receive an activation code. You feed in the application activation code, and after that the provider, that is the app vendor, sends the code to health insurance, and they check it and they reimburse the provider. So in step 3 you would actually get to use the app. And that's, I guess, it from this presentation. It's available in Health Innovation Hub's site. I downloaded it from there yesterday. The other thing I did was I went into this DiGA website and looked at some, for instance, facts and figures of the DiGA directory. So pretty recent stuff, less than a week ago, it was updated. There have been 95 applications in total, and 70 of them have targeted the provisional listing, so without final proof of the efficacy of the application of the app. And then 25 applications going straight to the final listing in DiGA directory. App vendors who think that they already have good enough proof that the solution works. And the results of assessment, by now there have been 20 positive decisions, and these are all listed in the DiGA directory. There have been 4 negative decisions, and 45 vendors have withdrawn the applications. They have noticed that, okay, there's this thing, this and this and this thing that we haven't yet worked on, and we need to work a bit more, and then resubmit our application. And 26 applications are currently being processed, so expecting to see some more content soon. And this is in BfArM the website, so if you go to BfArM and medical devices and DiGA, you find this. And then there is the DiGA directory, and if you launch that, you get into this kind of page, and that is in German. But luckily I learned German some 25 years or 30 years ago in school, so I was able to decipher some of it. So I can open the DiGA directory, and hey, here we have 20 different applications listed. And if you go, you can go and search for all of those. I picked up some stuff. So first of all, different kind of indications that these can be used in. There's, for instance, well, Mika, I think, had quite a few. So there's this Information für Fachkreise, and they had all these patient groups listed that could use the Mika app. And still one single application that you can get from App Store, Google Play. And do you need hardware? No, you don't need hardware. So let's make this a bit larger. You can see it better. And the cost is 419 euros per 90 days. Some other examples. Let's take Mawendo. This was an interesting one because this was actually the only one that didn't have the 90 days charge period. Here it's one-time license of 119 euros, and this is for kneecap injuries and treatment of those. And they say that, okay, the foreseen least amount of use would be 12 weeks, but it's not limited. You can use it for the rest of your life, I guess. Some other examples. There's Rehappy, for instance, and they actually do have a hardware component. So the first time use of this app, it's 449 euros for the 90 days, but that includes the energy band that you use with the app. And after that, in subsequent 90 days periods are 299 each. And yeah, plenty of examples. I also made an Excel out of these. So 20 different apps. Some of those had been published. Let me show that again. So here in the DiGA Verzeichnis page, you have these Bekanntmachungs, so notices from the BfArM team that approves these applications. Some of them have been listed here, but the latest one is from July. And not all of these, the 3 latest ones, didn't make it there, so they have been approved to the 12-month period in July and August, and Forvida is actually a permanent listing and couldn't find out when that was added. But anyway, 20 applications offerings in total. The highest price is more than 700 euros for 90 days. The cheapest is this 190 euros for one-time license. 2 applications have a hardware component listed, and 4 of these are permanent listings, and the other ones are this preliminary listing where you have the 12 months to show the efficacy of the product. And here you have the times when they have been processed in the BfArM, so some resubmissions for the apps. And actually, one more thing about the Invirto app. So you don't necessarily see everything from that, like Invirto, it's one listing, but then when you go into this listing, you have actually 3 different apps. You have one for agoraphobia and one for social anxiety and one for panic attack. So different apps, and all of these require the use of VR glasses. So that would be my short presentation on the DiGA model and the current statistics of that. Any questions or discussion? Fredrik, go ahead.
Yeah, I wonder, does this compensation model also includes services that are run through the apps? So it's just apps, or can it be service combined with the app?
Right. The guideline is that the digital part needs to be the main part. If it's just an app that connects you with a physician, a nurse, or a doctor, and you discuss, then it's not a DiGA. Then that's a different model for reimbursement, and that is for the personal cost. So it doesn't preclude. You might have some, for instance, a nutrition app. They gave this example that you might have a nutrition app, and there might be a team of nutritionists going through all the meal photos sent by different people. But if you go to a direct contact between the patient and the practitioner, then it's not mainly digital. So I think it might be very well defined there, but the main purpose of the app for sure shouldn't be just connecting you with a human. So it needs to be mainly digital. Terhi.
Thank you, Mikael. Do you know if they have made any kind of research whether these companies benefited? What was the benefit for these companies? Did they get some money out of this? Because they have to pay. You have to pay to be DiGA. It's not free.
Yes,
exactly. And another comment is that there is a lot of companies, I think, who decided not to go just because it's too expensive, or they think that they will not benefit enough, or whatever. Yeah.
That would have been my specific question as well. And I'm not sure whether even B-Farm is able to tell that information. For the apps that are in app stores, you could go to app stores and see how many times those apps have been downloaded and make some kind of estimate out of that. And there are services that give you even more detailed look into the download numbers and so on.
They didn't make any research out of this. Okay, they just started 1 year ago, so this is
and actually started this year for real.
Yeah.
So I don't think anybody has really gained net profit out of this yet, my guess. But still, something like medium 500 euros per 90 days. You need some time and a bigger population, but it might be economically feasible. I think the biggest reason why companies are hesitant is because this is so new, and okay, let's leave it to somebody else to try it out first and see how it goes. Jaakko.
Yes, I think that interoperability was one of the aspects that they were reviewing in the application. So I don't know if you know what standards, for example, or systems that they are kind of expecting that the application would be interoperable with.
Yeah, I checked that at some point when DiGA was still in the draft phase. And at least then there were no hard requirements for interoperability. So not being interoperable doesn't preclude you from being a DiGA. But at least when you, for instance, make treatment easier, or there were these process benefits that you can get, then having interoperability helps. And if you can use that to standardize care between the different parts, for instance, or if you interoperate with the electronic health record system, the main tool of the physician, if you're able to connect there, then it's easier for you to prove that, yes, we save time because all the data comes to the tool of the physician right away. So not sure about the current hard requirements or software requirements that there are.
Okay. Thank you.
Anders.
Now, I just want to emphasize on the last question regarding your presentation about how is it going with the DiGA initiative, and of course, as I addressed as well, one of the main reasons why we have to look at this as a system and not a standard is exactly what to do with the solutions when they are gone through the process. And it's very easy when you start looking into it, because there's a balance between the industry perspective of this and the healthcare perspective of this. If we only live within the healthcare bubble, we would like to have everything assessed in any way or form we can to make sure that it is as trustable as possible. But then no one will go through the process. So if you take the industry perspective, we should have as few requirements as possible, more or less, to make it as easy as possible for anyone to go through. And these two areas have to go hand in hand. We have to have requirements that is built upon and ending up with trust, but as few as possible to make it as motivational as possible for the industry to go through the evaluation process, but at the same time have many enough that makes it trustable for the healthcare sector to start using this, or for the individuals to start using this. And we have to take into account, whenever we start thinking about how to evaluate digital health, we have to in parallel be thinking how to activate those solutions once they are evaluated.
Yep.
Because we will find ways of evaluation. It's not a problem. We will find ways. It will have to be balanced enough for the industry to be motivated and for the healthcare sector to trust it. But that balance we will find. So I think we can take it as granted that we will have evaluated solutions, but then we have to think how to put this into practice, how to put it into the hands of the right people, because otherwise the business model for the industry will be not good enough and they will disappear.
Correct.
And then we have gained exactly nothing.
And experience.
And experience. But the industry will not be there with their solutions because there was no business model to finance the upbuild of their solutions. And the healthcare sector won't have anyone that is quality assured because they disappear. So that balance, and that is addressing two different sectors, one of them being the Ministry of Industry, which has a responsibility for building up the industry and making sure that the industry is booming. And then is the Ministry of Health, which is then responsible for healthcare safety and all of that. So it's a tricky area to work in, but we have to think about it as a system and have focus on activation as well as and in parallel with the accreditation or evaluation process.
Yeah. Another insights from DiGA consultants that they keep bringing up is it also touches what Terhi asked before. So how do you actually make money out of this? It's such an early days that just having your app out there doesn't help you at all. Healthcare changes slowly, and you really need to put a lot of effort and legwork into going to doctors, going to nurses and say that, hey, we have this beautiful product and this is how you actually benefit from using it. And you need to do all that marketing and sales work in order for them to prescribe your app.
And I think that Tim also can echo that. When I'm looking at the work that's been done in England, where they are a lot of years ahead of us, one of the challenges I seem to see is of course that they now put a lot of focus on the activation part.
Yeah.
And that's where I want the Nordics to be learning from that experience and have a balanced approach, that someone is putting their heads together and saying, how do we make sure that the evaluated solutions comes into play and comes into active use, because otherwise the whole system will die.
Correct. Currently, as an app developer, I still envy the German market. I want to go there because there is a clear business model, whereas in the Nordic countries we are still okay. We wait for Anders to come up with a perfect solution, but it won't be next week or even next month.
But based on the insights that you now have from the DiGA solution and being a Nordic representative, where do you see the challenges of utilizing the way of thinking from DiGA into a Nordic welfare model? Is it a copy-paste, or is it challenges that we don't see?
Well, the next speaker, Anna, is from Kela, and that is the kind of reimburser in Finland, the payer role. I know Anna doesn't work in that department, but still I see that Germany had an easier task bringing this up because they were in the very bottom of digital health. They realized that they need to do something. They were willing to push a lot of public money into making this fly. And also, I guess it was a bit easier with the health insurance companies, so they already think in commercial terms and so on. But really interesting to see what come up with in the Nordic countries where we have this strong public healthcare system. But now I guess it's time to let Anna take the scene. Go ahead.
Yeah, thank you, Mikael, and good afternoon, everyone. So yes, my name is Anna Korpela, and I work as the sort of a technical product owner of Kanta Personal Health Record in Kela, an organization that is responsible for the technical implementation and maintenance of Finnish Kanta services and Kanta Personal Health Record. And I think we've had very interesting presentation and discussions today so far, and now I'll try to tell you or shed light for you about the new certification requirements for Kanta Personal Health Record applications, actually on behalf of the Finnish Institute for Health and Welfare, or THL in short. That organization is actually the body responsible for setting these requirements according to our upcoming Finnish legislation. And in addition, I promised to give you a brief update on what's going on with Kanta PHR currently in general. But I'll start sharing my slides now, and unfortunately it might be that my video will go away, as at least in the past this web application of Teams has not allowed me to share both at the same time. But let's see what happens when I start sharing. I think I'm now sharing the PowerPoint. Let's just share that if you don't see it. But yes, good. Yes. So before we start with the Kanta PHR update, I thought that just in case if there's someone there who might not be that familiar with Kanta services or Kanta Personal Health Record, I will first very briefly explain these services for you, so you get a general idea of what's the context of the requirements and the certification we're going to talk today about. So yes, Kanta is a unique nationwide solution for safe recording and seamless use of health and well-being data. And it's developed in cooperation with several organizations, and well, first of all, STM, this means the Ministry of Social Affairs and Health is of course funding the development and maintenance of Kanta services. Then there's THL, which is the Finnish Institute for Health and Welfare. We have Kela, which is my organization, and we're responsible for the technical side. And then, of course, we do cooperate with social welfare and healthcare providers, and of course, with software and application developers as well. Here you can see an overview of all the Kanta services. So they do consist of several national centralized data repositories for health and well-being data. And the data is stored in and utilized from Kanta services by social welfare and healthcare staff, pharmacies, and citizens as well. So we do have different separate centralized data repositories for patient data, prescription data, and social welfare data. And now with Kanta Personal Health Record, we also have a national centralized data repository for citizens' own health and well-being data that the citizens can store and utilize with different well-being applications that integrate to the Kanta Personal Health Record platform. So that's just a very brief oversight of what Kanta services are. So next, let's go through a brief update on what's going on with Kanta Personal Health Record before we go into the certification of these applications that integrate to Kanta PHR. So many of you know, but there's a few you don't know, Kanta services as well as Kanta Personal Health Record are based on legislation. And this autumn, a new act on electronic processing of client data in healthcare and social welfare will enter into force, and this will happen in November. And this act itself enables us to actually further develop the Kanta Personal Health Record. The act includes the sort of law or legislation basis for Kanta PHR, and it does enable us to actually maintain and develop the platform itself where citizens can store their own well-being data. The precondition here, of course, is that these applications with which the data is stored in Kanta PHR, they first have to actually integrate to the platform. And this is where the certification part of the Act comes in place. So the last point on the slide here, it states that the Act itself actually does regulate the certification of these applications, and I'll tell you about that in more detail later on. And also an important part of Kanta Personal Health Record is the fact that in the future the Act will enable citizens to give their consent that the data they stored in Kanta PHR can be shared with healthcare and social welfare professionals. So yes, we have new legislation coming up, and here are some of the latest changes that are made to the or were made to the Act before it was accepted. So the first point here is actually related to the certification of the applications. So accessibility requirements were added to the Act and the requirement list of Kanta PHR applications. Secondly, a point related to sort of data privacy issues. So my organization, Kela, will become the controller of the wellbeing data that's stored in Kanta PHR, and this will actually affect the terms of delivery that the application suppliers who integrate to Kanta PHR have to agree to. And the last highlight here relates to underage users of Kanta PHR. So the legislation is not that clear on this point, and we are currently looking into what can and will be the future age limit of Kanta PHR as the new Act comes into force, but it's still under clarification. But as soon as we come to an agreement on what it can and should be, we'll of course tell you about that. And there's also a link to some previous material that I've held in these PHSIC workshops. You can take a look in that if you're interested in other aspects of the Act that I've previously told you about, and if you haven't seen that material. Then the Act does include some transition times for some functionalities related to Kanta Personal Health Record and wellbeing applications. So first of all, sharing of data from Kanta Personal Health Record to social healthcare professionals should be implemented and ready for deployment in Kanta services in the beginning of 2024. So there's a slight change in that. It was previously, I think, June 2023, but they did push the transition time to a bit more in the future. Then the Act also enables sharing other data that's stored in Kanta services to citizens through wellbeing applications, and these have some transition times as well, and they vary a little by the type of data that's in question. So prescription related data has the transition time in December next year, patient data a year after that, and then social welfare data is available in the May of 2025, the latest. Then a few words about technical development we're currently doing to the platform. So the HL7 FHIR standard, currently we're supporting version STU3, and now we're completing our support for R4 version. We've published our profiles at Simplifier in the Finnish PHR R4 project, and the support is currently available in our sandbox environment. So any app developer wanting to test their application against the R4 supportive Kanta PHR or version of Kanta PHR can do that. Joint testing that's required from the applications before they can start using the R4 version in production is not yet open, but we'll let you know as soon as soon as we can open the joint testing for that. Then where we've trying to get a production image environment together, and it's going to become available after our next platform release or update. And the production image environment is a production-like test environment where application suppliers can carry out independent testing against Kanta PHR. And it's mainly meant for those application suppliers that have already integrated their application to the production environment. And this environment does have the corresponding application versions of the Kanta PHR that are in the production environment as well. But this is something that some of our clients have been waiting on, so now we managed to put it up. Then about conceptualization that I've I think told you in these workshops also before. So it's now starting this autumn, and this conceptualization is also led by THL. And the objective, for those who don't know, is to clarify the use of these citizens' own well-being data in social and healthcare in Finland, and to also clarify the role of Kanta PHR. And we are having the first workshop next week on Wednesday, and it's organized by the HL7 Kanta PHR support project. And the agenda next week is actually quite related to the agenda of this workshop today and the discussions we've already had today, since the agenda will be to discuss the possible business models for Kanta PHR applications in more detail. So if you're interested in this topic, please do come and participate in that workshop we're having next week. And there's a link to a registration form in this material if you're interested, so you can register for the workshop. Okay. Now let's move forward to the certification part and the certification process and requirements that the new Client Data Act will demand of Kanta PHR applications. And like I said, the certification itself is also based on legislation and the same act that's coming into force this November. And the act states that an application integrating to Kanta Personal Health Record has to be certified before it can actually be deployed in production and integrated to Kanta PHR. And the Act itself sets 4 kinds of certification requirements for these applications, and they are related to interoperability, data security, functionality, and the newest edition, accessibility. And the Act then also obligates the app supplier to actually follow the certification process that is based on the Act, and during that provide any proof that the application actually meets the certification requirements. So the work we're doing by my organization and the work that THL is leading is basically based on the Act, and we're sort of trying to work around these limitations that the Act sets for us and the legislation sets for us. So yes, more specific regulations are coming, and they're currently in the making by the THL. So they will give more specific regulations about the certification process itself, or the procedures related to it, and actually the actual certification requirements also. And a proposed certification process and the requirements should be published by them this week, and it will be open for public commenting. So if you're again interested, and I strongly encourage all of you who can and are available to participate in the public commenting. They will be published on THL website, and you can find the form with which you can comment there as well. But as the materials are not yet public, and as they would be only in Finnish if I did have the materials that will be published, I can show you the actual materials today, but I've gathered a few slides here based on the information that I've received from THL that will hopefully give you some insight into what they are going to propose based on the Act. And first, let's go through the draft certification process of how the certification probably is going to go. It does consist of 5 main phases, and the first phase is joint testing that is conducted in collaboration with my organization, who is responsible for the technical implementation of Kanta PHR itself. And the objective with joint testing is to ensure that the application does meet the interoperability criteria and requirements that are set for the application, and also to ensure that they're interoperable with other applications integrating to the platform as well. As the idea of Kanta Personal Health Record is that with one app you can store data there and then maybe take another application that can utilize the same data. So we have to ensure that this application and the data they store to Kanta PHR is actually interoperable. Then after joint testing, the second phase is a data security audit that is conducted by an outsider or an outside data security assessment body, and the app supplier will receive a certificate on conformity from this, and it's valid for up to 3 years. And this is an audit that costs, and the costs have to be, or the application supplier does have to pay for all the costs related to this. The third phase is to notify Valvira, which is the National Supervisory Authority for Welfare and Health in Finland, and they publish this registry of all the certified applications. So before phase 4, which is production deployment, the application supplier has to notify Valvira about the upcoming production deployment and that they're going to integrate to Kanta PHR, and then Valvira has to also publish the app in the registry before phase 4 production deployment can take place. Then the last phase of the process includes responsibilities for the app supplier that take place after production deployment. So the Act itself actually states that the app supplier has to follow user experiences. They have to inform Kela and Valvira of any significant deviations in data processing or in the when the user is using the app. They have to inform any significant changes made to the app, both to Kela and also the data security assessment body, so that they can evaluate whether a new joint testing or a new data security audit is needed. And then the app supplier also has to follow any changes made to the certification requirements and go through the process again if the requirements change in a way that requires a new certification for the application. So this is a draft process, and it is based on the Act. These are all regulated there. Then if we take a look at the certification requirements next that are being proposed for these applications. So several different sources have been used as references for these requirements, both international and national. And for those who are familiar with the current acceptance criteria of Kanta PHR applications, these new certification requirements will be based on those, and they have been somewhat modified to fit the demands of the new act and the requirements that are regulated there. In practice, the requirements are gathered to an Excel form, and the application supplier has to fill the form and then deliver the form to different participants of the certification process. So for Kela, the data security assessment body, and to Valvira as well. the proposed requirements, there are a few different categories that they've been divided into. And as I said before, the Excel form is not publicly available, and it would be only in Finnish. I've tried to gather a description of the different categories here on the slide. So let's try to go through them with this material that we have at hand. So the first category is basic requirements, and first of all, it does include a few requirements about the basic background information related to the application supplier, and the intended use of the application, so that the different participants in the certification process would get an idea of what the app is about in general. There are requirements related to obeying any legislation that's in force. There's some requirements related to following technical specifications of Kanta PHR. However, there's another category for the interoperability requirements that will go maybe even further into the technical aspects. The basic requirements also include requirements for the so-called integration apps, and by this they mean apps that store data to Kanta personal health record from other applications, and also the other way around. There's requirements related to apps that transmit data from Kanta personal health record to other applications. The basic requirements also include requirements more specific to the actual end users. So end user testing will be mandatory, and also there will be requirements related to what kind of support for end users the application and the application supplier should provide. And there will be requirements about user documentation, what kind of user documentation has to be provided, and how the user should be informed about the application and how the application actually works. There's also some requirements related to third-party advertising if the application does include third-party advertising. The next requirement category is about data security, and these requirements will be verified in the data security audit conducted with the data security assessment body. And these requirements include many requirements that are based on the ISO standard that we heard about today. And then there are some more specific criteria or requirements as well. So storing sensitive data to logs or cache is not allowed. And then as Kanta PHR is based on the FIRE standard, there's a requirement related to following that standard's safety checklist. There are requirements related to following the authorization guidelines of Kanta PHR that are based on OAuth. There are some requirements related to forwarding and sharing well-being data if the application does have such functionalities, and these requirements are mainly from the perspective of data security. And then there's requirements related to data integrity in cases where an application stores the same data to Kanta personal health record and to some other location as well. So there are requirements on how that should be organized and how data integrity should be made sure that it stays good. The third category of requirements is about data protection and data privacy, and these are mainly also based on the ISO standard, and they're related to processing any personally identifiable information and GDPR. Then there are three more categories of requirements, and the first here is functional requirements, and here the requirements focus on sort of what kind of data the application actually produces and uses, both from and in Kanta PHR, but also outside of Kanta PHR, because some applications might process more data that they actually store or use from Kanta PHR. So these requirements target that. And then there are some specific criteria about giving instructions related to health and well-being if the application does have such functionalities. Accessibility requirements, as I told you before, the Act does require accessibility from these applications integrating Kanta PHR, and as Kanta PHR is a national service, the applications have to fulfill the accessibility requirements that are regulated in the Finnish Act on the provision of digital services. So this is one of the newest additions to the legislation that I think was made this spring, just before it was accepted. And the last category of requirements includes requirements related to interoperability, and these will be verified in the joint testing. That was the first phase of the certification process, and there's going to be requirements related to each of the sort of technical interfaces that the app will use in Kanta PHR. So the requirements related to authorization and how the authorization should be implemented in the app will be there, and these are actually mandatory for all applications. But then the rest that are related to storing, updating, reading and searching, or deleting data, it will vary, of course, depending on the app, that which of these functionalities they have, that which of these requirements they have to fulfill. But here we try to ensure that the data processing and storing of data is done in a manner that ensures interoperability when other applications also utilize the same data. And in addition to applications used by the citizen, then in the future also applications used by the social and healthcare professionals who can also utilize this data. Yes, I think that was the end of my presentation, and actually that was the last category of the requirements. So I think maybe we have a time for a few questions. I'm not sure if we're going over time a little bit.
Yep, we have time. So we have the next 10 minutes, the official time for this meeting, and at least I can hang around for another 30 minutes if there is discussion. But any questions or comments to Anna? Jaakko.
Yes, in the context of the Client Act, you referred to the possibility to send the patient data to the patient. But do you know if that happens through the Kanta PHR or directly from the Kanta services? I think that has been an open issue earlier.
The current plan currently, I think, is that there will be it won't go through Kanta PHR, but there will be their own interfaces straightly to the patient data repository or the prescription data repository.
But the same certification process should apply to those, or is it different then?
I think the process itself is probably similar, but the requirements have not yet been thought about. So these requirements that I just presented are for applications that actually integrate to Kanta PHR and utilize well-being data. But there might be other requirements when the using of official patient data comes into picture.
Okay. Probably they will be partly same applications that would need both of these features. So
yes, it might be that they can be the same, or I think it could be possible that an application integrates just to use patient data from Kanta services. So that's why I think they're going to also go through and think about the requirements separately from this one, and also because it might be seen as a little different type of data than the well-being data. So they might be I don't know, some kind of different requirements that they have to consider in that case.
Okay, thank you.
Any other comments or questions to Anna? I have one. You mentioned the conceptualization workshops for Kanta PHR, and you asked people to come. Is that invitation open to all people, even them from other Nordic countries, or is that Finnish special team?
Well, I think the idea is to talk in Finnish, so that might be a restriction. I don't know whether THL would be open to an idea of doing this in English. So that might be something that should be discussed with them since they're sort of leading the workshop.
So my question to the audience, would there be any interest in participating if it would be in English and welcoming everybody?
If I may say something, I think all of these workshops is really interesting. I do understand that some of the national discussions is perhaps a bit restricted when they have to do it in English instead of the local language. But I just want to say thank you for the presentation from Kanta and the initiatives. And it is a bit working in the Nordic level. You Finns are doing a lot of smart things, also when it comes to legislation. So you're moving ahead of the rest of the country. So currently we are always using Finland as a good example, and I have to stop doing that from time to time because people are saying, well, Finland is something different. Finland is something. Might not be that you living in Finland is feeling it the same way, but you're doing a lot of smart things. So it's really interesting and inspiring to see some of the things that you're moving forward with. So discussions around this, I would be glad to take part in, but I do understand that moving it from Finnish to English is limiting the discussions a little bit. So if you have a workshop and you have some good findings, then you can send me a summary.
Thanks for that, Anders. And I do feel that Finland is a bit different country, but I hope that you will harmonize the Nordic market to be on the same level all around. Markus.
Yeah, I would like to actually check if I'm understanding this correctly, since I have in my calendar, I have 5th of October, this kind of meeting of conceptualization of
yes,
this
I think
event.
I think that's a different workshop that evolves around the conceptualization as well. But that was organized. I think that's the one for. I'm sorry, I don't know the English word for it, but sote-kokonaisarkkitehtuurityöryhmä. So it's a different workshop, but might have the same or agenda or this issue also in the agenda. I'm not currently sure what the agenda will be.
The English term for that is the behind the scenes ivory tower.
Well, maybe yes. Architectural work group that includes representatives from THL and Kela and the ministry and from the social and healthcare providers as well, at least.
Okay, but yeah, good to know that there are actually different kind of different meetings. Yeah,
yes.
Thanks.
And Terhi.
Thank you, Anna. It was really a nice presentation, and I liked all your visualizations of this. Quite a dynamic process where, like 3 years ago and what is now, we have the new legislation and how the process will be. I'm, as those who know me, I'm always asking about the money. So have anyone seen estimation how much this the process will cost to a company, to a app developing company? So I would like to hear some, euros.
Yeah, I can answer from my perspective first. That's a very interesting question, but I think it might be a bit difficult to answer yet because the requirements, for example, that will be verified in the data security audit have not yet been public yet. So I don't think that even these assessment bodies can actually give an estimation of how much this part will cost. Since they haven't seen the requirements themselves, they don't know how sort of big of a job this assessment will be.
But are we talking about tens of thousands of euros? I
don't know. I'm not sure if anybody else has a wild guess.
Mikael is nodding.
But I don't. At this point, I think it would be better that I don't throw in a guess because it's not based on actual facts.
So compared to DiGA process, Mikael, what do you say? What is your opinion?
My assumption is that for a company like Sensotrend, the Kanta PHR is still cheaper because in DiGA process there's a lot of paperwork that you need to produce in German, and that is an additional cost for us. And
but you can German.
Yes, I can read German, but producing German is different.
In that level, so to speak, it's difficult. Okay, but it's going to be costly from a startup.
I'm looking for is that, for instance, this data security audit. Again, let's not duplicate the effort. If we need to pay a Finnish data security audit and then a German data security audit, then that's absolutely ridiculous, and we'll fight for that not to be the case. So if we make one first, then we should be able to take the data security audit certificate from the other process and then reuse it in the other one.
And I don't totally understand why there is a data security audit. Of course, I have nothing against it, and of course, Parliament has also learned something about the Valvamo scandal here in Finland. But okay, we'll see. It's nice to see the legislation, going forward in Finland. We have waited for the new legislation so long that I'm all for it.
Yes, quite a few years. Yes.
So I would say let's try again this kind of open space coffee break. At least I have some 30 minutes reserved after this workshop. If you need to go, if you want to go ahead. But if you want to hang around with like-minded people and discuss reimbursement, business models, technology, anything around digital health, do stay and let's have a conversation.
Maybe one thing to say before all people go away is that Anna's presentation, Anna mentioned this possibility to comment these requirements for certification. So I think it would be good if we distribute a link to this comments request through the mailing list, because it's very much in the core of this group to comment and at least read that specification. So if Anna provides that link then to Hannu, so Hannu could then
yes,
send
I think Minna from THL will do that when they do publish it. Yes, but me or Minna will give it to Hannu.
Yeah, that's good. And at the same time, Hannu can. Before that, I think we have all the slides in the online service in the HL7 pages. So he can also send the link to the slides if that is okay for all presenters. We collect those. So please, presenters, send those slides to Hannu or Mikael, either one.
Yep.
And
Jaakko, do you want to share a few words about the work you did on the secondary use that might be of interest for this group?
Yes. I can just maybe share by saying that one of the projects that we had for HL7 this year was related actually to Mikael's presentations in the sense that Mikael referred to using real world data in kind of showing the impact of the application, and access to real world data is a bit tricky still, and there is in Finland this FinData organization which takes care of kind of register-based research for providing the data permits for clinical data resources for research and for showing how applications work and whatever this kind of secondary use of data. But the thing is that in FinData service they are dealing only with let's say the official patient record data and the national registers. So one interesting thing is that how we can actually provide access to wellness data that is produced by the individuals and not kind of ending in the healthcare, the official systems. Especially currently, they are not. They are only in the Apple or Google servers, and how we could actually use those for secondary use purposes and research. So for that, to investigate how this could be done, we carried out a project where we interviewed some people and some different types of organizations that have interest in this kind of use of data, and which are important in kind of facilitating for that kind of use of data. And the report is published. I have some problem in my system. I cannot put anything in the comments field now. So, but we can distribute the link. Maybe is Marketta there? No. No. So, but at least we can share it together with Anna's link on the certification requirements. So I think that's maybe the summary. If someone has anything to discuss on that, we can have take questions.
Thanks, Jaakko. I'll see if I can share the URL in the chat.
Did you find it, the link?
Yep.
It's on VTT
Yeah, I found
server. Okay, you found. Good. There is something strange in my Teams now happening. So. But that report is in Finnish, so that's the limitation in that.
I also can't access the chat in my computer, but I can through my mobile.
Okay. Yeah, it maybe is coming from the fact that we are kind of visitors in the Teams system now. for
I
some
visitor
reason.
both.
Yeah. Okay, but I think we are only 7 left, but thanks, Mikael, for leading this through, and also replacing DiGA representative for this meeting.
Yeah, it was interesting going through the latest figures.
Yeah, that's interesting to see what happens with this kind of, if we end up with this kind of reimbursement in Finland someday. It might take some time, but would be good option also for companies to have to fix the business model, which is lacking now.
For sure. Kirsi, if you are online, you can stop the recording. None of others of us can do that. If not, then it will just log out.
Yeah. And thanks
Right,
for
I will.
Thanks for
Thanks.
Kirsi for organizing this as long as you were in the team.